Welcome to my presentation, The Dying Person, Ethical Challenges in End-of-Life Care. As healthcare practitioners, we witness death all the time. Sometimes it could be quite tragic. Sometimes it could be peaceful, where we could see family members around the person. So this presentation will speak about the challenges, especially the ethical challenges in end-of-life care. I think everybody deserves a dignified death as well as a dignified life. Preparing for death often means finishing a life's work, setting things right with family and friends, and making peace with the inevitable. Spiritual and religious issues at end of life are very important, and many families feel they need clergy around them to have support at this time. Also, the grieving process. Grieving often progresses through 5 emotional stages, them being denial, anger, bargaining, depression, and acceptance. The prospect of dying raises questions about the nature and meaning of life and the reasons for suffering and dying. No easy answers to these fundamental questions exist. Every death is unique. Every family member's feeling about that is unique. Every patient is unique. You must respect all of this. I would like to discuss some of the main objectives of this presentation. I'm going to speak about the ethical considerations at the end of life. Some people have an advance directive. Some people have a living will. Some people have neither. I also want to talk about assessing decision-making capacity. Sometimes people do advance directives and living wills at the end of life, and maybe their decisions are not the best. When you are dying, I am sure your mind is not exactly making the best decisions. You know, you have fear, which is normal. I'm also going to speak about the subject of withholding treatment, and I'm also going to be speaking about hydration and nutrition. A lot of hospices believe in not giving hydration, not giving nutrition at end of life, and I'm going to speak a little bit about that. I'm also going to speak about medical futility, and I'm also going to speak about physician-assisted suicide, which is now legal in New Jersey and certain states in this country. I wanted to cover some of the topics I will be speaking about today. This presentation is about the ethical challenges at the end of life. And I want to cover certain aspects of that as we go along. First, I will speak about death with dignity. Certain states allow physician-assisted suicide. A lot of people want to die with dignity. I've seen many patients in the ICU who actually don't die in a dignified manner. I've seen them intubated. I've seen tubes everywhere. I see them surrounded by nurses and physicians and respiratory therapists who they know, we all want to take care of them, but we really don't know them very well. And that's not really necessarily a dignified death. I also want to talk about assessing decision-making capacity. A lot of people who are terminally ill sometimes make some poor decisions on their choices. A lot of times they will write up a living will, or they'll write up a power of attorney because they are concerned about their end of life, and they really want to make the right choices, but the question is, are they making the right choice? I'm also going to talk about withholding versus withdrawing treatment. There's a difference between withholding treatment versus withdrawing treatment. Withholding, for example, could be that you did not intubate, you did not do resuscitate, it was not a DNR. Withdrawing treatment would be a terminal extubation. They are different. Then I'm going to talk about the concept of the doctrine of double effect. I'm also going to speak about artificial nutrition and hydration, which is a hot topic in palliative care and in hospice care. I'm going to speak about medical futility. Medical futility is there are many patients out there who are dying. And sometimes promises are made to these patients that they have a chance of survival, which is not real. Medical futility is to try to do something for the patient that's not going to actually measure up to any kind of real benefit to the patient. And then finally, we're going to get into physician-assisted suicide and euthanasia. More and more patients across this country are choosing this method, and I don't want to give nothing away at this point, but as we go along, I'll be speaking more about it. This is a case study of Margaret. Margaret was a 60-year-old woman who lived alone, and she kept her own apartment. Her apartment was always not necessarily neat, and sometimes her refrigerator was not filled with the proper food, but she was quite independent. She wanted to be alone. She didn't want to be in a nursing home, and her family was quite concerned about this. Sometimes she would forget her children. They noticed that over the last few months that she was forgetting who her children were. So she was calling her children by other names. And her family thought that she had Alzheimer's. They were wondering what's going on with her. So they brought her to a physician and they did a diagnostic test. They did a CAT scan and MRI. And regrettably, she was diagnosed with a glioblastoma. And the doctor told that this is basically an untreatable brain cancer that you can't do much about. And it says, we expect your life expectancy with this prognosis is around 16 months. So they said this could be the reason why she's becoming forgetful. You know, she never really had a history of Alzheimer's before, but now this is coming to light. So Margaret at this time said, she doesn't want any treatment. And the physician said, if we give you treatment, we could really extend that 16 months to 24 months, or maybe even further. But she was quite adamant. She says, no, I don't want to do this. And her children went off the rack. They went crazy with her decision. They did not agree with her. They disagreed. They thought that maybe she's not making the right choice. The glioblastoma, the cancer, really wasn't making her making good decision capacity. So in other words, she refused treatment. The children were saying they want her to take treatment, and they're saying the reason she's refusing is that this medical condition is actually impairing her decision-making capacity. So what do you think? Who's right? Who's wrong? So earlier I was telling you that one of the ethical choices made at end of life is assessing decision-making capacity. So in the case of Margaret, was she competent? Was she making the right decision by refusing treatment? So who's to say she's wrong? So how do you go about it? So basically, in these kind of conditions, you may have to test her decision-making capacity. And some of the criteria for this, you need to be able to communicate. You can't be mumbling words. You need to be able to communicate that this is your decision. You thought about it, and this is the way you want to do it. And you need to be able to say this verbally and make some kind of confirmation that this is what you want. Also, you need to be able to understand treatment options. You cannot just blow off a treatment option. You need to understand what the treatment is. You need to be able to say, you know, maybe if I take this drug, I could live another 6 months, but, you know, am I going to lose my hair? Am I going to be nausea? Am I going to be in pain? What's going on? I don't know if I want to be in that kind of condition for the last 6 months of life. Also, you need to be able to grasp the consequences of accepting or declining therapy. So what that means is, okay, I choose not to take this medication. The consequences of this is that my diagnosis or my prognosis might be coming true and that I have only 16 months to live. So you really need to be able to determine what are the consequences of accepting or refusing therapy. And finally, the ability to reason. You need to be cognitively equipped enough to sort of rationalize why you are doing what you want to do. If you pass all of these tests and you decide not to take any kind of chemotherapy for your cancer, who can question you? But if you can't make a decision, that's a whole nother story. So what about the concept assessing decision-making capacity in people with depression? If you are dying, do you feel that you will not be depressed? I think if you know that you are dying, that the concept that you're going to die absolutely is going to have some kind of impact on your mental status. Can you be depressed about it? Of course. Is depression normal? Of course. Sometimes depression is abnormal. I am not a psychologist. I am not a psychiatrist. I would not be able to diagnose if someone's depressed, but there are professionals who can. So in the case of the depressed patient, and they are making decisions on end-of-life care, you really need to get a team involved. And the team could be a psychiatrist who's a professional in this. You could get a surrogate. A surrogate could be somebody who knows you so well, knows what your wishes are, and they could sort of communicate with the team exactly what was going on. This also could be done through an ethics consultation. And these kind of decisions got to be really carefully weighed, because sometimes you may say you want to withdraw or you want to withhold care. So you might say, I do not want to get that therapy, or I do not want to be intubated, and that could maybe be a bad choice on your part. And also, I could do a whole new lecture on this, but the ethnic and cultural variations between people changes. There are many different ethnic groups in this world, and they each have a different thought about end of life and who's involved with care for them. They may not believe that I need to bring in a psychiatrist, or I'm going to bring in an ethics consultation. They may say, this is my family's choice. So when someone's depressed, you really got to make some good choices about exactly determining their mental capacity. One of the most difficult concepts in healthcare for healthcare workers as respiratory therapists, nurses, and doctors is withholding or withdrawing treatment. What that means is if the patient has competent decision-making capacity and knows exactly what they want and what they don't want, if they choose to withhold treatment that could maybe potentially save their life, they have the right to do so. The problem comes with patients who do not have the capacity to make good decisions, and then this would fall on the surrogate. If there's no advance directive, and now it falls onto the healthcare team. But from a healthcare point of view, or healthcare worker point of view, this is one of our most difficult decisions. For example, if a patient comes into the emergency room in cardiac arrest, and the doctors decide to intubate, and then the wife is there saying, no, do not intubate. My husband's been intubated in the past and doesn't really want to be intubated anymore. He has an advance directive. And the doctors say, oh, if we don't intubate, your husband will die. She says, but I have an advance directive. And the doctor says, where is this advance directive? And she can't produce it. So they intubate the patient. A few minutes later, the son comes into the emergency room with the advance directive and says, my dad should not have been intubated, and now we got to extubate him. Sometimes extubating a patient like that, it can be very difficult because you know the outcome is going to probably be death. But if they produce that advance directive up front and you withheld intubation, that is a big difference. We feel differently as healthcare workers. So really, some of the most important factors you got to consider is patient autonomy. Patients have the right to make decisions on what's going to be done and what's not going to be done. As long as they're competent and they make good decision capacity, they can make their own choices. So the question is, what is the role of the physician in this decision? Does the physician have any role to trump a patient's decision? If a patient is competent and just says, I do not want to be intubated, does the physician have the right to trump him? I ask you, what do you think? Also, withdrawing care is much more emotionally difficult. Like I was saying before, if you intubate somebody or if you make a terminal extubation, this could be a very difficult process for the healthcare worker. I remember the first time I did a terminal extubation, and I was really sort of upset about it because I am a Catholic, a Roman Catholic, and I just sort of believe that, you should not kill. And I felt in a way I was killing the patient. I've come a long way since then, but it's a difficult choices to be made. So there is a difference between withholding, withdrawing treatment, but from a legal and moral point of view, they are equivalent. You may not have heard of the doctrine of double effect, but I wanted to explain exactly what it is, and I also want to give you an example. The doctrine of double effect applies to interventions that both have a good and bad effect on the patient. The intervention may be used with the intent to achieve a good effect, but with unforeseen consequences causing a bad effect. This is permissible if the intent is clear for a good effect. I notice a lot of mumbo jumbo, but let me just put it down into you a way you might understand. If a patient came into the emergency room and says, my foot hurts, and the doctor takes off the shoe and his foot is gangrenous. It's like completely green, black. There's no blood supply. And the doctor says, oh my goodness, he says, I'm surprised you even made it here. He says, your foot is necrotic. And he says, we have to bring you up in the emergency room. We have to bring you to the OR and we have to amputate your foot. And the patient says, no, I don't want it to be amputated. I had this foot my whole life. Give me some antibiotics. And the doctor says, no. He says, antibiotics can't help this. This is like so far gone. He says, you're going to probably get septic. And the patient says, no, I want antibiotics. I want antibiotics. The patient is not making good decision. So because the physician realized that this patient is not making good decisions, they decided to bring down anesthesia. They intubate the patient, they bring him up to the OR, and they cut off the foot. 2 days later, the patient wakes up in the ICU. The fever is gone. The amputation was a perfect case, and the patient is healthy and living, minus the foot. So this is an example of the doctrine of double effect, where the patient was harmed. That patient's wishes of keeping his foot was not held, and the doctor went against his wishes and hurt that patient by removing the foot. But the patient actually lived and was healthier after that. Otherwise, the patient would have died. That's an example of a doctrine of double effect. This is another example of the doctrine of double effect. Sometimes at end-of-life care, patients are in a lot of pain. And one of the best ways to relieve pain is the use of morphine. And sometimes you may have to give so much morphine to the patient to relieve the pain, to make the patient more comfortable. In other words, you're doing the patient good. But the side effect of too much morphine could be you could suppress their respiratory cycle and they could die, from respiratory arrest. So the question is, this is another example of the doctrine of double effect, where you give morphine to relieve the pain and do better for the patient. But the flip side to that is that potentially the patient could go apneic from the morphine and die. So this is another example of the doctrine of double effect, and it happens all the time in healthcare. This is a particularly hot topic in end-of-life care. It has to do with artificial nutrition and hydration. And what that means is, in the terminally ill patient, evidence supports withholding nutrition and hydration in these patients. And you may be saying, what the hell, you're going to kill them that way? But evidence points to some major benefits. Number one, with less fluids and hydration, you have less cough, less chest congestion, and possibly reduced pleural effusions. You don't need a catheterization because you're not really doing some urine output, so you don't have to get a catheter. You don't have bloating and diarrhea that caused by end-of-life processes. You don't get leg edema. You don't get pain. Typically, studies have shown that most of these patients don't have a thirst reflex. In other words, they are not thirsty. So you may feel, oh my goodness, they're thirsty, they got a drink, and maybe you even notice that their lips are dry. Now, evidence also shows there's nothing wrong with giving them a little bit of a cool, moist patch on their lips to moisten their lips. Most patients in the hospital actually receive hydration, which is kind of funny. They're terminally ill and maybe they're on palliative care. And right now, at this point, a lot of hospitals end up giving them hydration. But in hospice, they really withhold fluids and hold food so they actually, go in a more peaceful manner. So you have to understand that artificial nutrition and hydration is typically withheld in end-of-life care, and all the evidence supports it. I wanted to discuss a little bit further that artificial nutrition and hydration, if it's being withheld on a patient, you really need to have a good discussion with the family to explain to them exactly why you're withholding it and all the evidence and so on. People, when they hear about that, you're not going to give them any fluids, you're not going to give them any nutrition, they panic. They think, oh God, you need this to live. But, if you really explain to them where the evidence lies, they sometimes understand. And each patient is different. You need to approach each patient a little bit differently based upon their history, based upon their prognosis, and so on. I'm going to present a case study on medical futility. And by the end of this presentation, you're going to know all about medical futility. There's an 88-year-old woman with a history of pancreatic cancer with metastasis to the liver and abdominal wall. She's also an end-stage renal disease and is on regular dialysis and recurrent respiratory failure. She's on a ventilator, she's trached, she's been hospitalized for over 6 months, mostly in the ICU, and she is being maintained by artificial nutrition and hydration, as well as sedation. New evidence has shown a tumor invasion of the abdominal wall with ulceration. She doesn't speak, and she has no living will. She has 2 daughters and a son. They are all educated and all professional. But any kind of crisis like this results in the family being dysfunctional. They're divided about what they want, and they're manipulative. Because there's no living will, no one has the power of attorney, so they're all sort of infighting with each other. They insist that everything should be done, and they are expecting a miracle to happen, and they pray and hopefully believe their mom will come out of this. They all feel that life is precious and that she's fighting on to live, even though she's not verbal. They don't know. They also want her to be a full code, but this is where the problem comes. The medical team, after having her for so many months and looking at her prognosis with all of her comorbidities, disagrees that this may not be the best choice. They have lengthy discussions about the detail about this patient every day. It seems like to be a conflict between what the healthcare team, which is the physician, the nurse, and the respiratory therapist, feel, and also the ethics committee, all feel that this patient is futile care, like her prognosis is very dim, the likelihood of surviving is really good, there's no living will, and you have a family who's divided about what kind of care she gets. So the question is, what can be done with this patient? Whose decision is it? Here you got this like I said, no advance directive. The family's fighting. The physicians and the medical team feel one way. The family feels another. So who wins? What's the story here? Who actually has final say on this? Because of the complexity of this case, there are numerous physicians involved, oncology doctors, ICU doctors, palliative care, everyone's involved. Sometimes, because there's so many people involved, there's conflicting messages and kind of confusing. No one's on the same page. Palliative care services was involved on different occasions, and they went in and out of this. In other words, it wasn't a steady palliative care process with this patient, and sort of the end-of-life care was sort of not really delegated properly. Respiratory therapists, nurses are all distressed about taking care of this kind of patient because they realize, just like you and I would just be able to see, the outcome of this patient. And trust me, when you work with patients like this and you see them up in the ICU for 6 months and you're taking care of them and you know darn well that they're not going to walk out of this ICU, this puts a lot of stress on us. This causes burnout on the job. This causes compassion fatigue. There's so many issues going along with that. But, we got to do our job. The family members are overwhelmed and sometimes unreasonable. They have a lot of pressure on them. They have a lot of distress in them. I mean, obviously they love their mother. So they actually created this ethics consultation because they really needed, because everyone's all over the place in such distress, they really needed to get together and create an ethics consultation. So the case study I just presented to you was a perfect example of medical futility. A futile care or medical futility is when anything you do, any course of treatment, will provide no beneficial outcome or is medically ineffective or even harmful to the patient. Basically, futile care is treating a patient with the prognosis that they are going to die in a short future. So medical futility is done all the time. Hospitals have many patients who I've seen through my career for the last 35 years that I've seen many patients who were treated in the ICU or in the general floor who were no way going to walk out of this hospital. And you think about it, the expense involved with futile care, end-of-life care, is this is the biggest chunk of medical expenses happens of end-of-life care. When someone's been in a hospital for months and they have so many comorbidities and there's nothing you can really do, they can't come up with a magic treatment, or medicine is not that advanced to a point where you could cure everything. Sometimes death is inevitable. So a lot of times you treat the disease and you don't even think about the patient. Oh, we're going to do everything about the blood pressure. We're going to do everything about, their white blood count or this and that. Whatever you're going to do, or you're going to do something to maintain their respiratory status. So the point is this: you treat the disease, but you don't treat the patient. The patient is suffering. The patient is in the ICU. The patient is not around with family. They could be around, but they don't even recognize who their family is. So medical futility is a real issue, and we really need to come to terms with it. I would say with palliative care and hospice, we've come a long way, but medical futility still exists today, and it's a real problem in healthcare. I wanted to give you a couple more definitions in medical futility, and one is called quantitative futility, and the other one is called qualitative futility. Some countries across the world use what is known as quantitative futility. And I'll read the definition, I'll give you an example. The likelihood that an intervention will benefit the patient is exceedingly low, less than 1 in 100. 1 in 100 is a very low percentage. That means that 99 people will die and 1 will live. So quantitative futility, some countries have these algorithms, computer algorithms, where you punch in the age of the patient, the sex, the primary diagnosis, comorbidities, you type in some lab values, and it ends up spitting out a result with a less than 5% chance of survival. Based upon the algorithm, which takes all the emotion out of everything, they may end up deciding to take her off medical support and let her go naturally. That's what they call quantitative futility. In this country, we have so many patients who are in futile care, and it's all based on emotions more than it is based upon scientific and medical facts. Qualitative futility means that, yes, they can live, but the quality of benefit of an intervention will produce exceedingly poor. Let me repeat that. Qualitative futility is the quality of a benefit an intervention will produce and it is exceedingly poor. What that means is that even with no matter what intervention you do with the patient, their lifestyle, the likelihood of them having a meaningful survival will be very poor. So these are different types of medical futility. So what is the role of the physician in medical futility? And the rules are almost across the country that physicians have no obligation to offer treatments that do not offer benefits to their patients. In other words, if a physician feels that the patient is hopeless and that there's no likelihood of survival, they can refuse treatment. Part of the problem is that you cannot just discontinue. The physician can't unilaterally decide to end support for the patient. They would have to consult with the ethics committee, and they would have to do this whole process. Also, if the family could find another hospital or another physician that would take care of that patient, the physician has the obligation and the hospital has the obligation to maintain that patient in the ICU until transport. So it's very, very difficult choice. Many physicians feel that it goes against their moral standards to actually maintain life for a patient who they realize the prognosis is almost zero. But they need to go through the process to do this, and it seems like the patient's right sort of trumps everything, at least in this country. So we have a patient in the ICU who is, the prognosis is really poor. What do you do? This is considered a futile case, that there's nothing that can be done for this patient. So the best thing you could do is, number one, is discuss with the family and surrogate exactly the prognosis of the patient, try to explain to them in a way that they can understand it. You could identify the goals of the treatment you give the patient. Maybe you want to withhold fluids and hydration like I was mentioning earlier. You might also want to discuss withholding or withdrawing medical interventions. This is a perfect example. This would be a terminal extubation. You need to obtain a consensus and a unified position on this. So you really need to work with a healthcare team. You need to work with the family. And sometimes you need to bring in third parties. Sometimes a psychiatrist or someone from risk management must come in to sort of speak to the family. Sometimes if all fails, and the Terry Chavallo story is a perfect example of that, you need to get a court-appointed guardian to make a decision. So when families can't make a decision, hospitals can't make a decision, sometimes you have to go through the legal rights of the state and also the patient. So very complicated. Most of my career was spent in UMDNJ, or University Hospital in Newark, New Jersey. It was a major trauma center. So my whole career and experience mostly is in New Jersey. I still do some per diem work here in Pennsylvania, where I live. But so what is the view of New Jersey in regard to fetal care? And this is very funny, or it's not very funny. It could be very sad. In New Jersey, patients near the end of life are treated with more aggressive medical care than in any other state in the United States. So what does that mean? That means patients in New Jersey are treated more aggressively, probably ends up being more futile care than any other state in the nation. I'll let you decide what that means. We're starting to go into the part where I'm going to talk about physician-assisted suicide. But before we go there, I need to explain a thing called autonomy. Autonomy is the right for a patient or a person to choose what they want and what they don't want. It is a God-given right that we can make choices for ourselves. You could choose what kind of food you want to eat. You could choose what kind of drinks you want to have. You could choose what kind of medical care you want to have. You could choose what kind of clothes you want to have. And it's the role of self-determination. Autonomy goes hand in hand with an advance directive. An advance directive is a written document that will explain all the things you want. So you do this when you're in a good decision capacity mode. You know exactly what you want, exactly what you don't want. You are making the decisions. This is called autonomy. And regrettably, sometimes our autonomy is taken away from us in various situations. So if you're going to make a decision on you are terminally ill, and you want to make a decision to have physician-assisted suicide, you got to do it when you have great decision-making capacity. And this is autonomy. This is a perfect example of autonomy when you make a decision on what you want in life and what you don't want in life, and you don't want to be sustained in pain, and it's your choice. So everyone has their own autonomy. Sure, you might have heard the name Jack Kevorkian. Many of us have heard the name because we lived through it. Many of us may have not heard this name, but let me give you a little background. Uh, he was a physician, and he actually was one of the first physicians in this country to perform physician-assisted suicide. So back in 1990, he actually did some physician-assisted suicide with a patient who had Alzheimer's diseases, and he was charged, but the charges were dropped from him. Then he went past and he actually helped more than 40 other patients do physician-assisted suicide. And it was kind of controversial, but what really tipped the scale is he actually went on 60 Minutes, which was a popular show on TV, and he actually performed physician-assisted suicide on a patient. He was convicted of second-degree murder and was jailed for 8 years. A little about physician-assisted suicide. While 60% of terminally ill patients support physician-assisted suicide, only about 11% would actually do it. So even if you are given a death sentence with your diagnosis, not too many people will actually take the step and take their own life. So Jack Kevorkian was one of the first physicians in this country, and it became a very public knowledge that he was like sort of, I don't want to use the word pioneer, but he was one of the first to sort of, broadcast what he was doing, and it actually bit him in the butt. So I wanted to give you a little bit more background on physician-assisted suicide. Physician-assisted suicide is granted in about maybe, I think, 9 states at the time of this presentation, and New Jersey is actually one of those states. So, but Oregon was the pioneer. Back in like 1995, they were one of the first states to actually conduct physician-assisted suicide, so they have the most experience. They created these laws called death with dignity laws, and death with dignity laws are quite specific. In other words, the patient, you cannot give a lethal drug to the patient from the physician or the nurse or whoever cannot give a lethal drug to the patient. The only way this can happen is if the physician prescribes a lethal drug, and typically it's Seconal or Nebutol. Seconal or Nebutol is basically a powerful barbiturate, and the dosing they give for this is so strong it actually puts you in a coma and kills you right on the spot. But they do not allow injection, so a physician will not inject you. So how it works, you go to a doctor, and they diagnose you with a terminal illness with less than 6 months to live. Then you need to go to a second opinion, and that other doctor needs to validate exactly what the first doctor said. So if 2 doctors agree that you are terminally ill and you have less than 6 months to live, you qualify. Also, you have to be able to make good decision-making capacity. In other words, you can't be in distress, you cannot be mentally ill, you can't have brain cancer that you can't talk and you can't make decisions. You really need to be able to make a good decision. Then what happens, the doctor will write a prescription and you go to your local pharmacy, CVS or Rite Aid, and you get the prescription. And what you do is you actually go back home and you sit in your favorite chair or you lie in your favorite bed and you put your favorite TV show on and you drink down these 2 pills or whatever the number of pills they are. Typically, they add another pill to it that will prevent nausea. There have been cases of patients who actually took the Nebutol and Seconal, and what they did was they vomited. And if they vomited during the process, they were left in this like comatose state and they did not die. So currently, they give another medication with that to prevent nausea, to prevent you from vomiting. So you actually take the pills and you die. And you really need to make your plans. And, I don't know if it's a dignified way to do it. I think it takes a lot of nerve, but I'm not terminally ill. I don't know if I was in severe pain, if I was knew that I was going to be dying in 6 months and I felt like I was a burden to the family. I don't know how I'd act. Currently being healthy, I can't even think about it, but people do think about it. And some of us agree. Question, do you agree with physician-assisted suicide? Do you believe a patient should be able to take their own life if they are terminally ill and they have 2 diagnoses? I put that question to you. Why don't you answer that question on the Q&A? I'm kind of curious where you stand. In regard to who approves or disapproves, 37% of Americans support physician-assisted suicide, 42% moderately approve. So when you look at these numbers, overwhelmingly, people approve of this process. I also wanted to show you 2 different methods that are used to end your life. I explained to you about the Seconal and Nebutol, which are barbiturates, and basically you would take these pills and you would swallow them with a glass of water and you go into a coma and you die. The image on the right is called a Sacro capsule. And basically California came up with this idea of creating this. It looks like a spaceship. If you're a Star Trek fan, this is like perfect, or a Star Wars fan. Basically, you go into this capsule, and slowly it depletes the oxygen in the capsule, and then you fall asleep and die. Now, you may think, oh my goodness, this has got to be a horrible death. But they actually use this method many times, and people seem to be very peaceful. They don't get distressed. So in other words, as the oxygen is depleted, you don't get distressed and flip out and start banging on the windows. Basically, you just sit there and then slowly the oxygen is depleted. Eventually you fall asleep and then eventually you die. So that's called a Sacro capsule, and that is another method for you Star Trek fans. This is a slide from the Death with Dignity Act, from prescriptions received and people actually dying. So they did this study from 1998 to 2015. The blue represents people who actually receive prescriptions. So these are people who've been diagnosed by 2 different physicians that they had less than 6 months to live. They went through the whole process. They did everything they needed to do, and they got a prescription. The green represents those who actually did it. So in other words, you may get a prescription, but you may even go down to CVS and get the prescription filled, but that bottle of capsules, you're not going to take it all. So as you could see over the years, more and more patients actually go this route. Many, many patients actually get more prescriptions, and many more patients actually take it, because you can see the numbers climbing up. Back in 1998, 16 people did it, and then in 2015, 132 people did it. Now, I'm saying this is only for Oregon, but this is actually across the country. As I mentioned before, I'm a Roman Catholic, and I was concerned about what is the church stance on physician-assisted suicide, because I always believe that if you took your own life, you go to hell. The church has said that voluntary cooperation in suicide is contrary to moral law. They didn't really exactly say you go to hell or it's no good. They also felt that suicide and euthanasia are never morally acceptable options. I asked different people who I did this presentation with, like Jewish people, Hindi people, Muslim people, and different parts of Christianity, and they all believe that taking your own life is not allowed. So the church, and whatever faith you believe in, most of these people feel that taking your own life is unacceptable. In summary, I wanted to give you some points. End of life choices are difficult to make. When someone is sick, someone is in a hospital, and it's a family member, you really sometimes speak from the heart and not the mind. You could be the most astute, medically correct person, but when it comes down to a family member or a loved one, you sometimes not make the right choices. A living will or an advance directive can really correct things. It could really give the patient autonomy and give them the choice what they want. Also, palliative care and hospice services has really improved. I remember palliative care at my hospital when we first started. It was less than perfect, but over time it really became really fine-tuned and good. And hospice service, I know 3 people in my circle of people I know who used hospice service at end of life, and it was a very dignified way. In reality, I think I would, God forbid my time comes up, I would prefer to use hospice service rather than dying in an ICU surrounded by people I don't know. If you don't know what you want to do or what you're going to say, speak to an expert. There's a lot of good people who out there who know this, who've been experienced this. You also might want to speak to other family members who experience similar issues. I hope you enjoyed this presentation, and on the next slide, I got some good references for you if you want to dig deeper. These are some very good references that I put together for you. So if you're really interested in learning a little bit more about end of life and palliative care and all these decision-making processes, this is a great place to start. And I want to thank you very much, and we'll see you soon.